Hello, my name is Dr. Mata, Moses Mata. I'm an adult neurologist based at Chipata Level 1 Hospital. And today I will be talking to you about an approach to cognitive impairment in adults. I would like to thank Dr. Jeremy Tanner, whose slides we are using for today's presentation. Cognition really talks about the mental process of acquiring knowledge and understanding the knowledge that we have acquired. And behavioral neurology is the study of the impact of disease on behavior, memory, and cognition. During the course of today's talk, we will describe the different domains of cognitive function. We will learn how to evaluate the different cognitive domains at the bedside, and we'll try to think about an algorithm or a system that we can and should be using when we are trying to assess cognitive impairment at the bedside. And we'll learn a little bit about the common neurodegenerative diseases that present with cognitive dysfunction. This graphic really just reminds us of the different lobes of the brain and some important anatomical landmarks. So the temporal lobe in blue, that light blue, we have your parietal lobe in purple, the occipital lobe in the green right at the back, and your frontal lobes. And in terms of deeper structures of importance, if I could just highlight the corpus callosum, which is a really important white matter tract that connects the left and the right hemispheres, and your diencephalon right deep in your brain. Again, this just highlights the different functional areas of the brain and some of the functions of the different parts of the brain. So your frontal lobe is really your executive function, your ability to plan and implement tasks, and to be able to behave in a socially appropriate manner based on cues that you're receiving from your environment, and our ability to problem solve. The left and right hemispheres obviously serve very similar roles, but there are some areas of specialization. So you know that on the left side, most of our language and speech functions are located on the left side. So our verbal memory, language memory, word finding are really a left temporal, frontotemporal function, whereas the right frontotemporal is really about design fluency, social skills, and non-verbal memory, and our occipital lobe is really focused on visual processing. The 6 cognitive domains that we are going to focus on are attention, executive function, behavior, language, memory, and visual spatial. So if we think about the first one, which is attention, and I hope that all of us have our attention fully switched on at the moment, because that's what you need to be able to choose and concentrate on a specific stimuli, such as listening to a lecture that is being presented. And this is really localized. It's a global process with multiple foci, but there might be a right hemispheric predominance. In terms of assessment, the history would really be suggestive, where you have someone who has difficulties concentrating or focusing on tasks, so they may struggle to stay awake and are easily distracted. And even when you're coming to assessment, you're going to look as you're observing them to see how they are attending to you. Are they paying attention, or are they easily distracted? And then you can do tests like word finding. You can do days of the week, just asking the patient to just state the days of the week and see how that goes from Monday to Sunday. Can they name all the days of the week in the correct order? And then you can always do backwards as well, depending on how well they perform on that particular task. Executive function. This is, like we mentioned, the ability to manipulate and process information to direct behaviors to achieve goals. It's really about the ability to plan and implement an action, a thought, whatever that thought might be. So this is what we need to keep jobs, to be students, to take care of ourselves. We are constantly problem solving, and this is a very important executive function, and it requires heavily for us to have a functional working memory, the ability to hold and manipulate mental information. Inhibition is also part of executive function. This is being able to impose restraints on our own behavior. We cannot act on everything that we would want or think to act on. So this is what allows us to function as parts of society, being able to control oneself. So when people begin to have problems of executive function, sometimes you see that they become disinhibited. So executive function is really a frontal lobe predominant cognitive domain. So anything that causes injury to the frontal lobes can really begin to manifest itself with changes in cognitive function of executive function. How do we assess for this? Again, it will be in the history. The person themselves or their caregiver will report that they have been having difficulties with planning and implementing tasks, difficulty performing tasks that they have previously performed with ease. Students may begin to struggle. Obviously, these are conditions that we expect in older people, so it's really things around the performance of jobs. People begin to struggle at jobs that they may have held for years and years and years. Behavior is how we conduct ourselves and react to stimuli that we receive from the world around us. Again, similar to executive function, this is really frontal lobe predominant, and it will manifest itself in changes in personality. People may begin to exhibit socially inappropriate behaviors, again, similar in terms of loss of inhibition. So they develop new mannerisms, compulsions. They may begin to have hallucinations, delusions, or paranoia. There are certain types of dementia, for example, that present quite heavily with behavioral symptoms. Frontotemporal dementia can present with quite significant behavioral changes. So a lot of this is just observation and recording what the caregiver tells us in terms of change in behavior over time. Language is an important cognitive domain, not just for things like dementia, but in many other neurologic conditions such as stroke. So most of us, whether you're left-handed or right-handed, our language and speech centers are really left predominant. So if you have an injury, any injury to your Broca's area in your left inferior frontal lobe, you may begin to manifest difficulties in speech production. Whereas if you have an injury that's predominantly affecting your Wernicke's area, which is in your superior temporal gyrus, you have difficulty with comprehension. And this will manifest itself in different degrees of aphasia, which is an acquired impairment of language. So at the bedside, we're really observing a patient's fluency. We're asking them to name items. When we talk about high frequency and low frequency words, these are just words that are either commonly used or not so commonly used. When we think about cognitive dysfunction and dementias in particular, we usually think around memory impairment, and it is true that the amnestic type of Alzheimer's, for example, is probably the most common type of Alzheimer's that we know, and this presents quite heavily with memory impairment. But as we've seen, it's not the only cognitive domain that can be affected. So when you talk about memory, we're talking about the ability to process what we learn, to store it and retrieve it later on for use. Initial learning is frontal lobe determinant. So again, you need to be able to be paying attention. You need to have a functional working memory. And then these memories are consolidated in our medial temporal lobe, in our hippocampus, so that when we look at images of patients with cognitive impairment and dementia, we really pay attention to the hippocampus and the medial temporal lobe, because we tend to see degeneration and atrophy in these areas of the brain, and that is a hallmark of most types of dementia actually. And then being able to retrieve memory, this is a very diffuse process involving the frontal, subcortical, and white matter areas. So in the history, you're asking about difficulty recalling conversations, events, especially episodic events, so things that happened recently. Patients with chronic cognitive impairment, such as dementia, they struggle more with recent events than with old events. History will be things like people losing things in the house, forgetting where they've put things, missing appointments, missing payment of bills. So these are problems of memory. At the bedside, and different screening tests will give you words to remember. So we can do a 3-word test. I use watch, belt, tie. I try to keep the same thing so that I can remember as well. And then you ask them to repeat it immediately. Then you do a delayed recall and recognition, where you give them a multiple choice list and then you ask them to name any of the words that they can remember from the options you have given them. Visual spatial really talks about the way we perceive items in space, and this is very important with cognitive impairment, because patients with dementia, for example, begin to struggle with visual spatial domain, and this leads to or contributes to high risks of injury. They are prone to falls. So localization is in the bilateral occipital lobes and bilateral parietal lobes. So these are patients who begin to get lost in familiar or unfamiliar places, a phenomenon called wandering, difficulty driving or navigating. So people who have walked the same routes, driven the same routes, suddenly having difficulties navigating things that they should know. At the bedside, we test for apraxia, which is really assessing one's ability to use familiar tools and gestures. So you can ask someone to demonstrate how you brush your teeth, and you find that the patient, they know what you mean, but they have forgotten how to perform the task. So this is a useful bedside test. Functional status is really cardinal to the evaluation of a person with cognitive impairment. So as we talk more, we'll kind of differentiate between mild cognitive impairment and dementia, and what does that look like, and even with dementia, mild, moderate, and severe, it really breaks down to one's ability to function independently. So if you have cognitive impairment, but you are still able to perform functionally, you are not dependent on other people to help you with activities of daily living, then you do not have dementia. So when you talk about activities of daily living, what do we actually mean? So there are those that we call instrumental activities of daily living. These ones you must be able to do for you to be independent. So things like shopping for food, being able to go to a shop with a list and buying all the things that you have listed, being able to prepare your own meals, being able to maintain a home, managing your own finances, managing your medications, navigating transportation. These are what we call instrumental activities of daily living. And then there are activities of daily living, such as being able to bathe yourself, dress yourself, toileting, being able to feed yourself, and being able to transfer yourself. This is really just moving from one point to the next, like from a chair into bed and vice versa. So once you start to see impairment in these activities of daily living, then you are now in the realm of dementia. With that in mind, how then do we perform a bedside assessment? We've talked a little about all of these, but just a reminder. So with behavior, You're really just observing how the person is behaving, how they're interacting with you, how they're interacting with family members and members of staff. Is it appropriate for the situation that they are in? You're going to ask orientation questions, just the basic person, place, and time. It will give you a lot of information. For attention, executive function, the days of the week, months of the year, backwards and forwards. You can do letters of the alphabet as well if you would like to increase in levels of difficulty. For memory, like we mentioned, it's a 3-item word list. Give it to them, ask them to remember it, and you ask them immediately, and over time again you do a delayed recall. Language, similarly, we talked about naming high and low frequency and giving 3-step commands. This really just means you are asking the person to perform 3 different tasks in sequence. So if I have problems with language, I may not be able, but also with attention, I may not be able to perform all 3 tasks. Executive function, visual spatial, we have talked about these. So with that background, we are now going to shift a little bit and talk about some of the different diseases that affect cognition. And here it's important that we differentiate between what an encephalopathy is and what an encephalitis is. So when we talk about an encephalopathy, here we're talking about, this is really a very broad term applied to disturbance of brain function, cognition or behavior that is not caused by central nervous system inflammation. Once you are in the realm of inflammation, remember itis means inflammation. So once you have evidence of inflammation, then you are talking about an encephalitis. And encephalitis is not the focus of today's talk, but there are quite a lot of overlaps, so we may mention as needed. Time course is a very important consideration when you're talking about cognitive impairment. Acute onset cognitive impairment, then you're talking about altered mental status and delirium. So hours to not more than 3 months, these are acute events, right? Subacute is 3 to 12 months in duration, and here we're talking about things like rapidly progressive dementias. And the chronic cognitive impairment are 12 months and beyond in terms of symptom onset and duration. And here we're talking about the dementias. History is your friend. It will always be your friend. The most useful information that you are going to get is going to be based on your history. So you want to get as much information from the history, and here you want to get some sense of history from the patient themselves, but also you need a reliable collateral history to collaborate what the patient is telling you and to give you some of the information that the patient just might not be able to because of the cognitive impairment that they are experiencing. You must establish a few things such as the handedness of the patient. Are they right-handed, or left-handed? Are they ambidextrous? You must try to establish the time course. When did all of these things start? Not when they got worse, but you want to know when did they start noticing problems. With dementias, this is going to be a chronic condition. It's going to be years, 3 to 5 years on average for most people, from the time that they notice symptoms to the point where it gets concerning. You must try to identify which cognitive domain was affected first, and then you must try to evaluate from your history which other cognitive domains have been affected. So let's talk a little bit about all the different things that we've mentioned here. So altered mental status, which is an acute event, this is really telling you that look for something reversible. This is an acute event, so there's potentially something that has triggered this, that if you correct it, might be able to resolve the cognitive impairment and return the patient to baseline. So There are different acronyms that you can use, but really just look for something that's causing it. Remember, this is going to be people of various ages. So again, depending on the age of the patient, the cause that you're going to be thinking of might vary from person to person. But you're going to look for metabolic causes of altered mental status. So abnormalities of glucose. Always look for hypo or hyperglycemia. Look for abnormalities in electrolytes such as sodium, calcium. You must do your thyroid function tests. Look for hepatic dysfunction. Hepatic encephalopathy can present with altered mental status. Look for renal dysfunction, and also evaluate for hypertensive encephalopathy. Infection, especially in the elderly population, 65 years and above, urinary tract infections, which may be asymptomatic in terms of pain, fever, all those other things, can present with acute altered mental status, so you must always look for them. Similarly with pneumonia, always think about CNS infections, and encephalitis and meningitis can present with altered mental status. Sepsis, from whatever focus, can also present with altered mental status. Is this structural? Is the patient having a seizure? So if I have a seizure, it is not uncommon to be altered in the post-ictal or even in the intra-ictal stage. So you must ask about a structural lesion such as a tumor. Has my patient had a stroke? Have they bled? Toxins, trauma, always think about trauma, head injury in a patient who presents with acute altered mental status. Think about toxins such as alcohol, either intoxication or withdrawal. Also medications, many antipsychotic medications can present with altered mental status as a complication. Narcotics and other drugs as well. Oxygenation, low oxygen or high carbon dioxide can also present with altered mental status. Delirium is an important differential to think about as well. So this is a cognitive dysfunction that's going to present with poor attention, and this is going to show itself either as a hyperactive or a hypoactive delirium, where you have a patient who has this waxing and waning level of consciousness and attention. The classic example of delirium is delirium tremens in patients who are withdrawing from alcohol or other substances. So always think about delirium, again, which is most associated with reversible causes when you have a patient with an acute onset of altered mental status. Why is it important to think about things like delirium? Because these are potentially reversible. They frequently cause hospital admissions, but if we can look for them, we can potentially reverse them. And unfortunately, if we don't look for delirium, it is very easy to miss, and it increases the mortality of patients presenting with this type of cognitive impairment. So always think about altered mental status, always think about reversible causes in the acute setting. So you always want to look at medication list, look for something that is causing it. Is your patient on sedatives? Is your patient on antipsychotic medication? Is your patient on any medication that could potentially lead to altered mental status? In terms of testing, you want to look for the cause. Always look for the cause. So if you're thinking about an infectious process, your full blood count is a good point to start. If you're thinking about deficiencies, B12, folate, if it's thyroid you're thinking about, so get your thyroid function test. Always look for HIV, always look for syphilis. The next category would be your subacute cognitive impairment, and here we're talking about the rapidly progressive dementia. Remember, we said that this is something where the symptoms have manifested in a period of a year or less, right? And the differential here is quite broad. When you think about the classic rapidly progressive dementias, we think about things like the prion diseases, Creutzfeldt-Jacobs disease, And there is a great review that I would recommend all of us to read by Michael Geschwind. It's from around 2010, but it still holds very valid today if you're thinking around the rapidly progressive dementias. This is a quite broad topic on its own, so we won't spend too much time at this point. And that brings us nicely to the dementias. When you have cognitive impairment that has lasted for 12 months and more, you are in the realm of dementia. So what are the dementias? The dementias are, it's an umbrella term for a group of neurodegenerative diseases that are chronic, they are progressive, and the hallmark is degeneration of neurons. And this leads to a progressive decline in function over time. And most of them are caused by abnormal proteins accumulating and spreading throughout the brain. We generally tend to classify them based on the severity that the patient presents to us. And different aspects of cognition are affected in different types of dementias, as we shall describe starting now. Some similarities between all of them are chronic, all of them are progressive. The first thing that most people will report is what's called a subjective cognitive impairment, in which the patient themselves recognizes that there is something that's not quite right, but if you were to perform tests at this point, the patient will usually do quite well on cognitive screening tests that are administered at this point, and they are still very functional. They have preserved daily function, and this is considered the earliest stage. Mild cognitive impairment, MCI, is a combination of subjective and objective impairment in at least one cognitive domain. These patients will still have really preserved daily function, but they are at a higher risk of progressing to dementia, so something in the range of 10 to 15% increased risk annually. But not everyone with mild cognitive impairment progresses to dementia after 10 years. And then dementia really is when you have subjective and objective impairment in at least two cognitive domains, and you also have functional impairment. So this is impairment in your instrumental activities of daily living or your activities of daily living. Why do we care about dementia? Because it is a huge, huge problem. We know that at the moment there are probably around 55 million people worldwide living with dementia, and this number is projected to increase to around 131.5 million people by the year 2050, and most of these are expected to be in low middle income countries. So as you can see, Africa, Zambia is not spared. We are working on data in terms of what is the prevalence of dementia in Zambia at the moment, because we do not yet have reliable data about this. What are the risk factors for dementia? I like to think about it in terms of whatever is bad for your heart is bad for your brain. Whatever is good for your brain, whatever is good for your heart is also good for your brain. So there are certain things that we know for a fact increase your risk of developing dementia. So lack of physical activity, hypertension, diabetes, all increase your risk of dementia. So therefore, when you talk about risk reduction, is really focusing on these modifiable risk factors. So increasing your physical activity, making sure that if you are hypertensive, your hypertension is well treated, and cessation of tobacco use, cessation or moderation, severe moderation of alcohol consumption are all approaches that we are implementing in terms of fighting or reducing your risk of dementia, developing dementia, or even if you already have dementia, there is still some benefit in implementing these modifiable risk factor modifications. This is a busy slide, but it really summarizes the most common types of dementia, and Alzheimer's related dementia is generally going to be the most common cause of dementia worldwide. When we talk about Alzheimer's, this is the dementia type that affects most people. Around 50 to 70% of all dementias are thought to be Alzheimer's type dementias, and it presents with chronic progressive decline in at least two cognitive domains. The amnestic type, with presenting heavily with memory loss, is probably the most common, but patients might present with other features before they have memory impairments. So again, going back to the different cognitive domains, just keep those in mind. The etiology of Alzheimer's disease really comes down to abnormal proteins, and we have amyloid beta plaques. So what you can see in the two, so you have two brain slices. One is a normal, and then the other one is an abnormal, and you can see the differences in terms of the atrophy. And if you look at the hippocampus and the temporal lobe, you can see significant atrophy in those areas, and you also have ventriculomegaly, where the ventricles are quite enlarged, which are features that you do tend to see in quite advanced Alzheimer's disease. The abnormal proteins, amyloid and tau, so you get these brown plaques and these neurofibrillary tangles, and these are the classic hallmarks of Alzheimer's disease. So classically you see them in the medial temporal lobe, in your hippocampus, but you may also have them in the parietal frontal left temporal parietal areas. For the longest, the diagnosis of Alzheimer's has been a clinical diagnosis, but the trend is towards a biological diagnosis of Alzheimer's based on confirmation of these abnormal proteins, amyloid and tau, using biomarkers, CSF and blood biomarkers, which are now available in some parts of the world, and hopefully in Zambia in the not too distant future. And then you combine that with evidence of neurodegeneration. That is a biological approach to diagnosis. I think biomarkers are really the next big step to simplify diagnosis. Previously, you had to wait for a patient to present with dementia before you could tell that they had Alzheimer's. But with biomarkers, we will get to a point where we can confirm that someone has these positive biomarkers even before they show clinical symptoms of dementia. And hopefully that happens at a point where we have effective treatments for Alzheimer's, because unfortunately at the moment the drugs that we do have use do not reverse the dementia. They do not cure dementia. They might help with functionality, but they do not cure. There are newer drugs that have recently been approved and are being rolled out. These are antibody therapies such as lecanemab. This is an exciting area of clinical treatment that may not yet be available in Zambia, but in the future, hopefully, we may have access to these as well. Vascular dementia, I think, is an area where we need to have a very strong conversation about in settings like ours, where we know that hypertension is a very big risk factor. So is vascular dementia more of a challenge, more of a problem than, for example, Alzheimer's disease? These are questions that we need to ask. So generally it is thought that about 10 to 20% of all dementias are vascular dementias, and the clinical presentation, whereas Alzheimer's is a really gradual over time decline, vascular dementias present more with a stepwise decline in function depending on the type and extent of the vascular injury. So as you can see on the images there, you have mild, moderate, and severe. So I'm just drawing your attention to the white spots. That is evidence of vascular injury. So the more severe, so these, think of them like micro strokes, small little strokes that people are having over time that might not manifest themselves clinically, as a stroke, but you do over time lose enough brain that your patient is going to present with a dementia syndrome. And that is why it's important that we really focus on identifying risk factors such as hypertension and managing them quite well, as well as dyslipidemias, diabetes. FTD, frontotemporal dementia, is, like the name suggests, a form of dementia that really affects the frontal and temporal lobes, meaning that patients who present with this type of dementia have quite strong behavioral symptomatology. So they are disinhibited, they may be apathetic, they may have hallucinations, but it is really the behavioral aspects that typify this. And the abnormal protein in FTD is TDP43, which was recently discovered. But you also have a type of tau protein, the 3-ARA and 4-ARA tau. In terms of management, here it's really around behavioral management. And the next couple of slides are links to clips of videos that kind of exemplify what FTD looks like. Please have the time to watch them after the lecture. Next, we're going to talk about dementia with Lewy bodies. This is quite a common dementia, probably second only to Alzheimer's for those who are 65 years and older, and it does have a very similar pathology to Parkinson's spectrum diseases and Parkinson's disease dementia. And these patients quite classically will present with hallucinations. They tend to have fluctuating cognition, and they may have Parkinsonian syndromes, movement disorders, quite very similar to Parkinson's disease. These patients are more prone to have dream enactment, so acting out their dreams, and the area that is affected is the visual spatial, which is primarily in your occipital area, as you can see on that functional MRI. So the areas that are lighting up are really in the occipital areas and the posterior parietal. In our setting, we cannot talk about cognitive impairment without talking about HIV, because we do know that HIV on its own, at the point of infection, actually, the CNS is one of the sanctuary sites for HIV. So patients, whether on treatment or off treatment, will over time present with some degree of HIV-associated neurocognitive disorders. Obviously, if you are not on treatment, the progression and the severity of your cognitive dysfunction can be expected to be much higher. So always think about HIV as a cause of neurocognitive dysfunction. And even for those who are already on treatment, when they present with cognitive dysfunction, think about things like CNS escape, where someone might be virologically suppressed when you do their CD4 viral load on blood, but once you do their CSF and you do a viral load there, you find that they have quite high viral loads, and you might need to think about changing the antiretroviral regimens that you currently have them on, and putting them on something that has a higher CNS penetration. Treatment is with an effective antiretroviral regimen. This graph just really shows the prevalence rates of HIV in different aspects of the continent of Africa, looking at the different age groups. This obviously is a slightly old slide, but with the advent of antiretrovirals, this has changed quite significantly and will continue to do so over time. So we are getting there. We'll talk a little bit about primary progressive aphasia, which is a neurodegenerative disease that causes a chronic progressive decline in language as a primary cognitive domain that is affected. So earliest and most impaired domain, patients start to struggle with word finding, and this causes significant functional impairment as they struggle to communicate. So patients may be non-fluent, they are impaired in speech production and grammar, or they might have a semantic variant of PPA, which presents with impairment in the understanding of the meaning of words. So again, this is just a type of dementia presenting with a particular cognitive domain that is affected more than others. So to summarize, we need to remember that we reviewed the domains of cognition and where they localize, and talked briefly about some of the tests that you could do at the bedside to evaluate for them. We talked about how you would approach the evaluation of a patient with cognitive impairment, starting with looking for reversible causes. We didn't really talk about imaging, but imaging is an important aspect of the assessment of any patient with neurocognitive impairment. You can, based on availability, ask for a CT or MRI. A non-contrast is a safe starting point. If getting imaging is not a challenge, MRI will always be superior to CT, especially for chronic conditions such as these neurocognitive disorders. But again, it falls to availability and the resources that are required for that test. And there's a reference there to a useful resource that I would recommend for all of us to have a look at.